Good morning, everyone. It is May 18th, 2015, and this is the monthly Q&A call for aEEG Coach. I want to welcome you if you're here live, or also if you're listening to this as a recording. And I'm just going to get started with a quick question that we have from Gabriel from Sao Paulo, Brazil. And the question today is about whether or not I think one channel or two channel is better. And it's funny because this is actually the topic I was thinking about presenting this morning, was two channels versus one channel. I chose symmetry instead, but I think one of the advantages, I'm personally in favor of at least two channels. I think that the benefit of that, and maybe I'll go ahead and do this on another call, but I think there are really some primary benefits. One is just being able to compare activity, specifically symmetry, which we are going to talk about today. And the other is the ability to identify more focal events. So you might have a seizure that's arising more from one side. And so I think that ability to be able to localize a little bit is probably the biggest benefit of being able to have two channels. So although I know it's more effort than just putting on a single pair, I think that at least two channels is my preference. And I think your question is also like what montage to use. I was always trained in the C3, P3, but I know that there are many people who do use the F3, P3 montage. And the rationale for that, especially in preterm babies, is that you're just going to see more surface area of the brain being monitored. And there aren't really, unfortunately, there aren't really that many kind of normative data for term babies, and even really preterm babies for the F3, P3. But the benefit of using F3, P3, and let me see, I think I actually have a little slide here so we can kind of all have a visual. So here in this particular slide, I'm highlighting the P3, P4, and this is exactly what I was just getting ready to say. So regardless of where you place the other electrode, whether it's C3 or F3 or F4 or P4, you always have the ability to look at P3, P4. And the advantage of P3, P4 is that's where all the normative data comes from. And so, and if you ever have anything unusual happening on one side or the other, you can always cross-check overall global health with looking at that P3, P4. So I think that the advantage of being able to look at symmetry, which is what we're going to talk about today specifically, is one of the strengths of doing bilateral monitoring. But I think it's always important to remember that when we're looking at kind of global strength of the injury, that going back to that P3, P4 will give you those established norms. So we may or may not have enough data to say, what are the exact voltages we should see with F3 to, F3, P3, F4, P4, so those bilateral channels. We do have some data about C3, P3, and C4, P4. We know that moving the electrodes that little bit closer together actually creates 1 microvolt drop in what would be the norm. So if you're looking at a C3, P3 or a C4, P4, and you have a microvolt lower limit of 4 as opposed to 5, that would actually be considered expected or normal when you're looking at a single channel. Now, perhaps by going a little wider, by going F3, P3, maybe you're able to achieve the same distance as you would with P3, P4, and therefore they'd be more consistent. That would be a great question for someone like Linda DeVries or Lena Hellstrom-Westis, who have been doing F3, P3 for a really long time. Maybe that's why they choose that. So I think it's a great question. Funny that you would ask it, because it was almost the presentation I gave this morning. Because there are a couple other reasons why I think multi-channel there's a benefit for that. But does that help? I hope. Okay, great. Well, so I'll dive in really quickly into this particular little Q&A conversation, which is what I found to be the three basic causes of aEEG asymmetry. So just as we were looking, the older traditional cerebral function monitors, or CFMs, or aEEGs, only had one pair or two electrodes that were active on the baby's head. And of course, this made things really simple, but what happened is that we only ended up with a single tracing, which was a real integration or combination of voltages coming from the left and the right. And although that is fine when you have babies who have two healthy hemispheres, there can be some issues with that if you don't. So by adding an additional electrode, so for example here at the C3P3 and the C4P4, so just by adding those extra central electrodes, and I think that we started adding these central electrodes mostly because these were already part of the traditional montage for neonatal EEG, and so we already had some voltage, I guess, history at these locations that we could have used, and their proximity to especially HIE injury, and knowing that parasagittal injury for HIE really happens right along this central sulcus and extending back towards the parietal lobe. So I think that's primarily the reason, because people were really mostly monitoring term babies with HIE when they first started doing this. And so I think that that's probably part of the rationale, is just that topography or the location of injury and ischemia. So anyway, so when we have a pair of electrodes on one side of the brain or the other, then we can look at those aEEG patterns separately. And sometimes we can see that they are different. I'm going to see if I can make this bigger, just so that it might be easier to see. So basically, pattern symmetry. So I sometimes like to show a picture of a butterfly here, because it's not that they are necessarily 100% identical in every way, looking at the left side and the right side, but there's definitely some synchrony that happens between the left and right hemispheres. And for the most part, I'm looking for, is the pattern, the background pattern, symmetrical? Not so much does every little blip happen identically on left and right, but would I, if I named these patterns, what would I say they are, and are they both the same patterns? So not to pick on Gabriel, but since you're here, I will. Let's see what happened to my slides. Let's see if it will get back to that page. So if we were to name the pattern on the left-hand side of this tracing, what would you say this particular left-hand tracing is? Would you say it's burst suppression? Would you say it's discontinuous? Would you say it's continuous? What would you say it is? Discontinuous, perfect. And then what about for the right side? Would you say that the right side is the same, or is it different? Is it also discontinuous, or is it low voltage? Looks the same, exactly. So in this case, although I could look at maybe 0600 and say, oh, well, the lower margin is maybe 3 at 0600 on the right, and then maybe at 0600 it's 4 on the left side. When you look at the overall pattern for left and right, they are both continuous. So there are differences, but they are the same pattern. And I think that's the part where sometimes people, when they're talking about symmetry, they're looking for exactness, or maybe they're saying, oh, well, there's this artifact here, so they're not symmetrical. Well, I'm looking at the overall, especially like a 3-hour tracing. Is the left and the right, are the patterns the same? So of course, symmetry is great to look at here. And then asymmetry, this is where we're looking at, again, the patterns. So if we look at the left side, yeah, wow, right? We look at the left side and we say, oh my gosh, there is definitely something different happening between these two patterns. There are many explanations, which we'll go into, but still we have on the right side that discontinuous tracing, and something has happened on the left, and we are basically at an extremely low voltage or practically inactive tracing on the left side. So, so what are these possible causes of this asymmetry? So I like to break these causes into three different areas or three different reasons. So one is that there's usually something happening extra cerebral or maybe an artifact of some sort. Then there is mechanical or technical issues, and then there is actual injury or focal injury. So let's go through a few examples of this. So I think one of the most common causes of asymmetry and areas that make you suspicious of things is artifacts, and especially EMG or muscle artifacts. And so we can see here on this particular tracing that there are times when the artifacts or the unusual patterns are very symmetrical, and there are times when it's not. So we sometimes see that electrodes get misplaced, or one side is placed more low and close to the temporalis muscle than the other side. But we oftentimes do see this asymmetry. Yes, and this artifact is very troublesome because it creates a lot of disruption to the aEEG band, which makes you go hunting for seizures, and you end up just finding a lot of this. So we see this with crying, we see this with shivering, we see this with sucking, and you know, eating with a bottle, breastfeeding, or just on a pacifier, we see this a lot. And so when I'm teaching people to place aEEG electrodes, it's important for them to just be aware of these muscles. And especially if you're using needles, people oftentimes start too low and end up that the needle is in too close of proximity to the those muscles. And so what they need to do is just start higher on the head in order to eliminate this artifact. So as the insertion site needs to be higher so that the electrode, you know, passes through just a, you know, above the muscle. And so a way to teach people this is just to have people take their fingertips and touch right above their ears and bite down. And even if you'll do it, as I'm talking, if you do this, you place your fingers right on your scalp, right above your ears, and you bite. I'm doing it too. You'll feel the muscle. And so I have them move their fingers up their head until they don't feel that muscle. And then that gives them a little bit of an idea of how high they need to be on the head in order to avoid this muscle. So that's definitely one that we see quite a bit. And sometimes it's hard to tell because the baby's heads are asymmetrical for whatever reason. And so you may not notice that someone has placed them a little bit lower on one side. But definitely we can see this kind of artifact quite a bit. The other artifact that we see quite a bit is high frequency. And so when we just have one channel of aEEG, we may not really be able to appreciate where the artifact is coming from. So you can see here where we've got this lower margin that just shifts up right around 1410, or around 1410. And this is a baby either changed position or was changed from conventional to high frequency ventilation. And for sure we see this kind of uprising. But what I've seen more frequently is this kind of a pattern. It is very difficult to deal with babies with high frequency. We oftentimes see that shifting of that bottom margin. But you can see on this particular tracing that this baby at 0600 was actually turned to the left side. So you know how when we have our babies on high frequency, they're usually pretty supine, but we oftentimes give them a little turn to just allow them to have a little bit of movement and to keep pressure points from getting out of hand. And so you can see on this one that when they turn the baby to the left, my guess is that the electrodes were getting quite a bit more contact with the mattress, which was probably getting a lot more jiggle and movement from the high frequency, and that the artifact just really went crazy on the left side. So we sometimes see this asymmetry pattern moving as the baby moves. So you can see that maybe at 0500, where this tracing begins here on the far left side, you can see that there was some elevation on the right side of this tracing. And if we were to have chosen that section, my guess is that we would have seen much more artifacts there. And then you can tell that the baby moved from the right to the left, that we have all this high frequency. And then around 8 o'clock, so about a 2-hour bit, either someone did something to relocate the electrodes or they repositioned the baby again, which wouldn't be too unusual for an every 2-hour position change. And that movement back at 8 o'clock actually created a change to the interference that we have. And then we're back to a pretty much burst suppression looking pattern at that point. So sometimes we see this alternating asymmetry from movement, or really not movement so much as position changes. So I do see this quite a fair amount. The other kind of troublesome thing that you sometimes might see, again, this transient changes in asymmetry, is a transient unilateral low voltage. So you can see here on the left side, starting at the beginning of the trace at 2257, that it's a very low trace on the left, and it is quite a nice normal trace on the right, and that right around midnight, where there's this green marker, you see this change. And the question is, why is this happening? Well, in this particular case, I actually got a picture of it, and this is the actual cause. We were using hydrogel electrodes that had migrated together. They were touching, and they were basically shorting themselves out, so short circuit. And then once you separate them back to their normal position, you have this return of a normal pattern. So this is where it's really not artifacts in that sense, where it's really just mechanical. The same can happen if a needle gets dislodged or something gets unplugged. Those can cause these intermittent shortings or just false asymmetry, really. So this happens quite frequently in premature babies. Their heads are so much smaller. The electrodes are closer together. Kind of going back to what we were talking about earlier about maybe that's a benefit of that F3P3 is that you get more distance. So you probably have less chance of these happening. But we find a lot that when we turn a baby, the head is squishy on one side. The electrodes, especially hydrogel electrodes, are very gooey, and they oftentimes are going to touch on that side where the baby is laying. Then you have the baby turn maybe more midline again, and then you see it resolve, and the baby turns the other way, and then you have that happening, that short circuit on the alternative side. So always really good to have people aware of this possibility so that they look for it. Another one that we see a fair amount is fluid accumulation, so edema or some sort of cephalohematoma or caput, where if the baby has a lot of fluid and you turn the baby to one particular side and that side of the head gets a lot of fluid pooling, dependent edema, you're going to see the electrodes get further away from the head or from the brain, and so it's more difficult for the electrodes to pick up those signals. And then you turn the baby to the other side, the fluid shifts, you get a better tracing on your other side and a worsening trace on the other side. So you can oftentimes see this fluid, dependent fluid, causing a real problem with asymmetry. So it's another reason why we sometimes see this. And last but definitely not least is that occasionally we actually have injury. So we might have asymmetry of actual brain activity. And in this particular case, we can see the baby's had a stroke, a unilateral stroke, and so that suppression that we see on the right side is really caused from that injury itself. And that's a definite possibility that you can pick that up using aEEG. So it is, this particular one is actually a stroke. It could happen, the question is, could it happen with an IVH? I think theoretically it is possible to see that. It is certainly something, if I see asymmetry in a preterm baby, I certainly worry about that. Because their heads are so flexible, it's difficult to actually create enough pressure that you will see actual depression of activity from that. I know that some people do report that. I personally haven't ever really experienced it. I've seen it happen in a baby. I've seen asymmetry occur in a baby who had that. We echoed them and didn't see anything. But it is possible, especially if it's a catastrophic bleed. The problem I see is just that their heads are typically so accommodating that you usually won't see enough asymmetry, but definitely possible. I just personally haven't really experienced it. But if you have some pictures of it, I would love to see them. So just usually I think of this more as a term baby who has usually suffered some sort of stroke. And I think just as a quick reminder, perinatal and neonatal strokes do happen in 1 in 3,000 live births. And it is the greatest lifetime risk is your first week of life. And important to think about, especially in an otherwise well newborn who presents with seizures, to really think of stroke as a primary cause of their presentation with seizures. So obviously there are many causes for seizures, but I think in an otherwise well newborn, we should always be thinking stroke. And when we're thinking stroke, we should be getting at least a 2-channel aEEG to screen for that, especially in places where you may have limited access to MRIs or even CT, I guess, in an emergency. But remembering that 40 to 50% of strokes, and in some cases, some people even report higher, many strokes are unilateral or focal. And with that, you will see a difference in EEG activity on the injured side. And it is important that we think of this as well. So I think just keeping that in mind. I have some colleagues who have actually detected strokes using aEEG on newborns who are admitted to the nursery for poor feeding or just, kind of a low tone, but otherwise doing pretty well, and then just put on aEEG as a screening, and then we're able to identify a stroke from that. So, or at least give them more suspicion and justification to go get imaging, which I think is sometimes, helpful in making that call. So, well, I'm excited, Gabriel, you said you maybe have a picture of a baby with severe IVH that showed asymmetry, and definitely I think there is for sure that theoretical possibility and obviously realistic possibility. And if you've got a tracing of it, I would love to see it and include it for people in the future. But definitely something to think about in those preemies if you're monitoring who are at risk for bleeds, for sure keeping that in mind. So great, love it if you want to send it. So that's kind of the end of my 3 different things to think about. So extracerebral, actually cerebral and maybe mechanical failures that we see that cause asymmetry. And the next call we'll be having is on June 29th. It will be the same time. And as just a very quick reminder, the course is definitely happening this year, and we are taking registrations for that. So we'll be starting back up on June 8th with our course, and we'll be taking, much more time to go into detail about these different subjects that we've even just begun to touch on in our Q&A calls. So I appreciate everyone who has joined us, and I will, if anyone doesn't have any other questions, we'll call it a call. We'll call it a call. Not that I meant to say it that way, but anyways, all right. Well, thank you for joining, and this will be posted up on the website later this week, and we'll get that going. Oh, there's a quickie question for what method do you use to score aEEGs in preterm infants? This is a great question. We actually had this conversation on the Facebook page this last week. I think most of us are still just using visual assessment. You know, for research, I think it's useful to have a tool. I think the current tools that most people use are really the Bergaloff scoring tool, which I think most of us would agree is quite challenging to use, and I think that the definitions are a little hard to grasp sometimes. So I think that's really the best one that we have. Otherwise, I think that just using the standard, you know, pattern recognition and pattern names with the classical definitions of those, with just by margins and voltage, I think is pretty much what most people do. I think that the community is definitely waiting for a tool to help us score aEEG patterns. And perhaps that's a good segue to just say that Gabriel has offered in the future to do one of his talks on preterm monitoring, which I think will be excellent, and maybe we can have a deeper discussion about the pros and cons of some of these tools. But Gabriel, I would welcome in the chat area if you have any other comments. Okay. Yeah, I think really most of us use Bergaloff, and I find it really hard to use. People oftentimes send me tracings to look at and say, I scored it at this, and what would you score it? And I'm like, oh, I have to pull out the definitions and really look at it. But it is really the only tool that we have other than, you know, I know there are some people who will split the lower margin discontinuous into like a high discontinuous and a low discontinuous. I think that's helpful if you're looking at just the lower margin and wanting to just make a little more discrete conversation about is there improvement. But yes, I agree. Many parameters are interrelated on these scores. Yeah, especially on the Bergaloff, where you're like, didn't I just do that? You know, it's really hard. But I think maybe I'll do a future Q&A call about the scoring tools, and we can maybe have a deeper conversation. Yeah, and Gabriel's mentioning that Monica Olishar proposed that classification of a discontinuous pattern. That's what I was just mentioning about low discontinuous versus high discontinuous, and really just saying, is it a discontinuous pattern, and is that lower margin between, I think it's 2 and 3 or 3 and 5. So just trying to say, you know, is the lower margin coming up? So it's one of those that I don't know that we would call it a tool necessarily for scoring, but it's definitely a way to kind of, I like how Gabriel wrote it here, a sub-classification of discontinuous, which with discontinuous, you're still going to see that lower margin variation and then go from there. Yeah, no, I think this would be a great talk for future. So thank you for that question. It was good. All right, everyone. Well, thanks for joining. And we're a couple minutes after 8:30 or whatever time 30 you are. But again, thank you for joining, and look forward to seeing you guys on another call in the future. So have a great day.